My name is Manesh Patel from Duke University, and I'm going to discuss an important study presented at the European Society of Cardiology 2021 and published simultaneously in The Lancet. This trial is called the Loop trial, a really hot topic. The question in this trial was, can we better identify patients with atrial fibrillation and then deliver oral anticoagulation to reduce their risk of stroke? The study was conducted in Denmark in several of the regions, 3 out of the 5 regions with many centers. They randomized 6,000 patients in a 1-to-3 fashion to one of 2 strategies. The implantable loop recorder was placed in patients, in about 1,500 patients, compared to the remaining patients who were medically treated usually for detection of atrial fibrillation. They enrolled any patient who was over 70 and had some of the usual risk factors for stroke, hypertension, diabetes, heart failure, such. And the average CHA2DS2-VASc score was about 4 in these patients. They hypothesized that the loop recorder would identify atrial fibrillation more frequently in those patients, and therefore once they were identified, they would get an oral anticoagulant and have a reduced rate of stroke. They hypothesized that the loop recorder would identify about 30% versus about 3% or 4% in the usual arm or clinical care arm. What they found wasn't a different detection rate of stroke over 3 years, which was about 32% in the loop recording arm. But about, instead of 3%, they found that it was 12% in the control arm. And so although this was statistically significant, there was only about a 20% difference there. And that translated at long-term stroke reduction rates of 4.5% of stroke and systemic embolism in the loop group versus 5.6%. And although numerically less, this was not statistically significant. One more important point was that loop recorder identified subclinical AF as just 6 minutes of atrial fibrillation that was identified, and then the indication for potentially treating those patients with oral anticoagulation. So what are my take-homes from the loop study? First, it really helps us better understand the value of subclinical atrial fibrillation screening. And what they found was that they were able to screen for atrial fibrillation and subclinical up to 6 minutes only and find patients. But this did not lead to a difference in stroke and systemic embolism out to 3 years. Now, we anticipate that there will be more studies coming on how we identify patients, and these were high-risk patients with CHA2DS2-VASc4. But currently, even in those high-risk patients, there's not evidence based on this study to do an implantable loop and then to orally anticoagulate those patients for subclinical atrial fibrillation.